Okay, so we're just starting the webinar now. So I'll request both of you to please open that your cameras, and then we'll launch the webinar now. We'll stop the practice session and start the webinar now. Okay, so good afternoon, everybody, and welcome to this MedEClasses Grand Round on Primary Amenorrhea. And this is going to be a very interactive and interesting webinar in which we'll talk about 4 very interesting cases of girls who presented with amenorrhea and where we found to have a lot of issues in terms of assessment and diagnosis. We are really happy to have 2 of our colleagues who have joined from across the country. Dr. Sekhar is there, who is a practicing endocrinologist at Rajmundry, and he is working in the medical college. Dr. Sekhar, welcome on board. And,
good afternoon, sir.
Good afternoon. And he'll be presenting about a very, very interesting case. Then we have got Dr. Guru Prasad, who is part of the MedEClasses course and program as well. And he is practicing as an endocrinologist at Bangalore. Dr. Guru Prasad, welcome to the program. So we'll start off a bit with regards to the initial aspects of what is the common causes of primary amenorrhea, particularly with the angle of what we are discussing today about tall girls with amenorrhea. Then we will use those 4 cases to see how these practical assessment tips will help out. And all of these cases have quite unique issues which are there in terms of diagnosis and management, which we'll be covering from that perspective. So we'll start off first of all as to why it is important to evaluate for amenorrhea and what can be significant implications which can happen in that perspective. So I hope the slide is visible now. So this is a 17-year-old girl with primary amenorrhea who presented to us with stage 4 breast development and also a pubic hair development, and there was no menstrual cycle. So there was a normal development otherwise, but there was no periods basically. She was a tall girl. Now this is a common concept which we'll talk about. All the 4 individuals we'll talk today were those who were either tall or had the potential to be tall, in that their bone ages were open and they had a delayed bone age in that perspective. It was found that the FSH level was high, LH was high, and estradiol was low. So our diagnosis was established basically of a hypergonadotropic hypogonadism and started on routine replacement therapy. Now, what happened on follow-up was a bit depressing, that the child actually developed a gonadoblastoma, and that was because a proper karyotype assessment was not done. And when we checked the karyotype, it was actually a XY phenotype. So it gives a big message that even if we have a classical feature of hypergonadotropic hypogonadism, we should look at karyotype. We have said that even if you have a child who looks entirely like Turner syndrome, even then karyotype is important because you may have a Y cell line. But if somebody is tall, then of course you want to talk about situations where you need to be very, very cautious in terms of assessment. So the theme today is about primary amenorrhea, particularly because of hypergonadotropic hypogonadism and tall individuals. So this basically brings us to a very narrow group, but a very important group of individuals who present to us with implications. Now, if we talk about primary amenorrhea, it's there around 2.5% of cases. Most of them would be physiological or functional in that perspective, but still there would be a significant number of pathology which we need to evaluate. Therefore, there is a need for meticulous evaluation in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources about pediatric endocrinology are available. Many of our courses are available in the form of fellowship and diploma programs, especially also for gynecologists as well as adolescent physicians. We routinely run 3 programs of PG lecture series and 2 grand rounds for the pediatric endocrinologist as well as pediatricians. And we have got publications which can be accessed both online as well as the hard copy, and our mobile application which helps making diagnosis very easy in that perspective. So the agenda for today is that we'll talk about 4 specific cases in a scenario where we have a girl who has amenorrhea with high estrogen. The second would be low estrogen and high androgen, an interesting case scenario. The third would be the issues with regards to whether there's a problem in the structure or the function, and then finally whether the gonad or the enzyme is defective. So these are 4 very interesting cases, all have common of having primary amenorrhea in a relatively tall girl with hypergonadotropic hypogonadism. So before we go that, we need to just have a touch base about pathophysiology of primary amenorrhea. So in that regard, we all know that there are 4 organs which are going to play a role. The hypothalamus pituitary as a unit, the ovaries, and the uterus. So all of them have to work in tandem to ensure that the periods happen. So we know that GnRH is a primary regulator of the gonadotrophins, which then synergistically add on the ovary. So LH acts on the LH receptor on theca cells to produce androstenedione, while FSH acts on the follicular, the granulosa cell, largely to produce aromatase, to produce estradiol. Now, both of them are synergistically required. What's important to understand is that in boys, LH is more important as compared to FSH. In girls, FSH is more important than LH. So abnormalities, isolated abnormalities in FSH or FSH receptor will cause a complete delayed puberty, no development, and primary amenorrhea, because you will have nothing, no follicle, nothing will develop. But abnormalities in the LH pathway, isolated LH defects, or if you have a LH resistance, will not cause primary amenorrhea. They will produce more like anovulatory findings in that perspective. If you put in the opposite perspective in boys, if you talk about abnormalities which are there with regards to the LH, you will have no pubertal development. So LHCG receptor defect, as we talk about, present to us with atypical genitalia. So very, very early and severe defect. FSH abnormalities will not have that much problem. You may actually have a high level of androgens, but the spermatogenesis may be defective. So just to put things in perspective, if you have abnormality in FSH, isolated abnormalities, you will have significant delayed puberty and primary amenorrhea. LH abnormalities may not cause that. Of course, GnRH and those problems will cause primary amenorrhea and delayed puberty. We will not focus that much on those groups today. Now, this estradiol is then converted from androstenedione via aromatase. So if you have a aromatase defect, you will have a sort of a situation in which androgens are high and estrogen are low. So the presentation in that scenario will typically be a child who has got some virilization at birth. Atypical genitalia will be there. The mother will also give you a history of hirsutism or virilization during pregnancy. And then things remain silent, and then later on they will present with estrogen deficiency in the form of delayed bone age and primary amenorrhea with delayed pubertal development. Of course, estradiol has to work on the estrogen receptor, and if there are estrogen receptor problem, you will again have problems which are associated with isolated abnormalities with regards. So if you have no estrogen action, the child will be born with a normal genitalia, because the default mode of development is a normal female. So zero estrogen action, normal female development will happen. Subsequent to that, the presentation will be delayed puberty, no breast development, and you will also have a problem in terms of amenorrhea. Now remember, because androgens are acting here, so your adrenal androgens are active, so therefore you will have a pubarchy which will happen in this scenario. So what I'm trying to do is to link up all this pathophysiology to clinical pointers which will help us reach a diagnosis in that perspective. Again, because estrogen is the major regulator of epiphyseal fusion, you will have a delayed bone age in that perspective. Of course, if you have a problem in the development of the uterus, particularly in the Mullerian structure, the upper 2/3 of the uterine, the vagina and the uterine development, you will have amenorrhea. These individuals will have normal breast development, normal pubic hair development, and they will have amenorrhea. So if you want to just assess clinically a girl who presents to you with primary amenorrhea, you have to look at three major things. What is the height? What is the breast development? What is the pubic hair development? And our algorithm will largely base upon this in that perspective. So abnormalities in the hypogonadotropic hypogonadism, that will be classical delayed puberty. Of course, you will have no development in that perspective. You may have pubarchy in this scenario because adrenal production is there. However, if you have a multiple pituitary hormone deficiency, you will also not have pubarchy. So pubic hair development is very important. Ovarian abnormalities like gonadal dysgenesis, the classical example being Turner syndrome with short stature, but many of the XY-DSD. So as discussed, XY-DSD is basically an act of omission, while XX-DSD is an act of commission. So something extra has to be done. So XY-DSD, any of the genes which are defective, they do not develop into testes. You will have a normal female development, which will happen. This will be associated with tall stature. As discussed, if you have a receptor problem, particularly the FSH receptor problem, you will have much more problems in terms of pubertal development. Abnormalities in aromatase will cause atypical genitalia at birth, followed by primary amenorrhea subsequently. If you have problem in the estrogen receptor, you will have pretty much a child who is a tall individual who has got reasonably high or an inappropriately normal level of estradiol. And then, of course, you have the structural defect. So primary amenorrhea can be because of a structural defect like a Mullerian abnormality or rarely imperforate hymen. That is something which is easy to identify but often missed. So if you have a young girl who presents to you with acute abdominal pain, and you find an abdominal lump, look at the breast development and ask whether there is a bleeding which has happened earlier or not. So this is a cryptomenorrhea, an easy diagnosis to make, but it is often missed. Otherwise, structural defects will have a normal breast development and a normal pubic hair development. Then if you have a functional defect, that means that you don't have a production of estrogen. You typically have either too little estrogen or too much androgen. So if there is androgen excess, also you can have primary amenorrhea, and this can happen in the setting of PCOS and CAH, and you will have hirsutism. Then if you have an impaired estrogen effect where you will have no thelarchy because there is no estrogen in that perspective. This can be because of resistance, which is estrogen receptor defect, where your estrogen levels will be relatively high, or you have a hypogonadotropic hypogonadism, central cause, or you have a high FSH, which is a hypergonadotropic hypergonadism. High FSH can be because of a XX DSD or a XY DSD. Remember, XY DSD can also have a similar manifestation. If the testis is not developed, it's damaged, it's vanished, you may have a complete female appearance in that scenario. The characteristic feature here will be tall stature. So as I said, tall stature means you may have XY DSD, as I discussed about the first case in that scenario. An interesting scenario is complete androgen insensitivity syndrome, which may also present to you with a girl with primary amenorrhea who has got good breast development but sparse pubic hair. So again, breast and pubic hair will give you the diagnosis in most scenario. And finally, you can have a biosynthetic defect. So if there is a proximal biosynthetic defect like star or side chain cleavage, you may rarely have salt wasting, but you may also have non-classical forms in which they don't have salt wasting. 17-hydroxylase deficiency will have hypertension, and aromatase will have hyperandrogenism along with tall stature. So 4 groups of disorders which will cause tall stature include estrogen receptor defect, XY-DSD, aromatase, and all these scenarios you need to be wary about in terms of assessment and diagnosis in that regards. So the key questions that a physician who is managing a child with primary amenorrhea has to answer is it amenorrhea? If it's amenorrhea, it's structural or functional, and what's the cause? Now, amenorrhea is classically defined as no menarche within 5 years of onset of breast development, or by 15 years of age you do not have, you have to start evaluating and working. So don't do unnecessary workup if it is not required in that perspective. The next question is structural versus functional, and for this you have to look at the breast and the pubic hair development. So if all the components of pubertal development is there and you have amenorrhea, you may have a structural defect. Rarely this may happen in the setting of somebody who was doing well, then develops an acquired cause of hypogonadism. So you may have a scenario in which somebody develops a brain tumor, somebody develops hyperprolactinemia, but usually if you look at breast and pubic hair, you will get the diagnosis. So this scenario, there is pubic hair development, but there is no breast development. It means there is a GnRH deficiency. So you have no estrogen production, no breast development, but because adrenals are working, this is GnRH deficiency, the adenarche is normal. If you have no breast, no pubic hair development, this could be a constitutional delay of puberty and growth, or it could be an illness, or rarely a multiple pituitary hormone deficiency, where also you can have a similar scenario. If you have a normal breast development with sparse pubic hair, you are usually dealing with the androgen insensitivity syndrome. And finally, if you have a normal breast development normal pubic hair development and amenorrhea, look for malformation, and that becomes relevant from that perspective. And these are very, very important in that regards. So if you want to differentiate now from a structural to a functional lesion, in a girl who has got thelarchy and pubarchy with a normal estradiol, it's usually a structural defect. Go for imaging, go for other aspects in that perspective. While if there is a thelarchy which is absent, pubarchy is variable, you have to think whether there is a hypogonadotropic hypogonadism in that regards. Now we know that this is a functional cause, not a structural cause. The next question is, what is the cause? So the key things to look at examination include hirsutism. If you have a girl who had a normal breast development, normal pubic hair development, but has significant hirsutism, think that this could be PCOS. We have seen so many PCOS with primary amenorrhea as well. So this is something to look at. If, however, there is no hirsutism and no thelarchy, it means there is a complete hypogonadotropic hypogonadism. In this regards, if they are tall, think of a XY-DSD or a estrogen receptor defect. If they have a normal breast development and sparse pubic hair, that is androgen insensitivity syndrome. If there is salt wasting as discussed, star, hypertension, 17-hydroxylase and aromatase, again, hyperandrogenism and tall stature, which will be there. So if you understand and look at the basic clinical parameters, you will identify these causes. So these are the various causes I've summarized. We'll go into individual aspects which will help us reach the diagnosis. So most important is that usually if somebody is not having periods, you expect the breast to be not there. But if there is a good breast development, you are dealing with either androgen insensitivity or hyperandrogenism or structural defect. Easy to identify in that regards. Pubarchy, if it's absent, you are dealing with androgen insensitivity, hypogonadotropic hypogonadism. Basically, if it is a very severe growth problem, especially because of a systemic illness or a multiple pituitary hormone deficiency. Hirsutism will indicate hyperandrogenism, and aromatase will also be a part of that differential. Now, very important, that's what the focus today is, height. Everybody who comes to you with delayed puberty should be short. We say everybody with precocious puberty should be tall. If you have a short girl, think thyroid. Similarly here, if you have delayed puberty with tall stature, there is something wrong going on. You have to think of androgen insensitivity. Usually you're thinking of a XY individual. So AIS will come there. Any other XY DSD will come there, and aromatase and ES1. So these are the four possible causes of tall stature with primary amenorrhea, and we will be covering all four of them. So this is just a hint as to what cases we're going to talk about today. FSH usually will be high in most cases. If you have a low FSH, you're dealing with a central cause basically. And of course, estrogen will also give you a picture. If your estrogen is high and you have amenorrhea, your diagnosis is there of estrogen receptor resistance. So if you look at the breast development, the pubic hair development, the height, the hirsutism, FSH, you will get the diagnosis in most cases in that regards. And finally, to put it in perspective, if your breast development is not there, you're mostly dealing with the hypo or hypergonadotropic hypogonadism. FSH is high, you have to work up for further. Estradiol is low, look for gonadal dysgenesis. Very important, do a karyotype. If estrogen is high, you will think of estradiol resistance. If you have got low FSH, you are dealing basically with a case of a problem of central cause, go for MRI. And if you have, on the other hand, a normal breast development and you have got no pubic hair, this is most likely androgen insensitivity, go for karyotype. If you have got good pubic hair development and hirsutism is there, work up for hyperandrogenism. No hirsutism, look for structural defect. The key message is no breast development, no periods, hypo or hypergonadotropic hypogonadism. Normal breast development without pubic hair, it is androgen insensitivity. Normal breast and pubic hair with hirsutism, PCOS. Normal breast and pubic hair without hirsutism, think of a structural defect. So this is what the overall thing is. And we'll now move forward to our presentations. The first case will be presented by Dr. M.V. Sekhar Reddy, who is an endocrinologist practicing in Rajmundry as assistant professor there, and the Center of Abhiram Diabetes and Endocrine Center. And this was a very interesting case which Dr. Sekhar had actually discussed with me, and it was really good to get the diagnosis out there. So Dr. Sekhar, over to you. Please start the presentation.
Okay, sir. Am I allowed to share the screen, sir?
Yeah, please share.
I hope my slides are visible.
Yes, please start. Yeah.
Good afternoon, everybody. For the next 15-20 minutes, I'll be discussing an interesting case, which I have been discussing with Anurag sir over the time. Today, I'll be discussing a patient of primary amenorrhea with tall stature and with adequate estradiol levels. Coming to her history, a 20-year-old female, first in birth order, product of second-degree consanguineous marriage, who was born at full term, normal vaginal delivery, with no significant perinatal history. There is no history of any crisis or any atypical genitalia noticed at the time of birth, and with normal milestones, was brought by her maternal aunt with a chief complaint of no menstruation for the last 5 years. Coming to the history of present illness, there is a doubtful single episode of vaginal bleeding, which was noticed only as a staining of her clothes following use of 3 to 4 cycles of OC pills around 5 years ago, and never had any further bleed after that. After this, the patient was continuously visiting multiple doctors and used many medications on and off for breast enlargement, but there was no improvement noted all along for these 5 years duration. And there was no history of any maternal virilization during pregnancy at that time, but there was history of death of younger brother at the age of 3 years due to a seizure disorder. And there is no history of any similar complaints in any other family members. And throughout these 5 years, there have been multiple investigations done, among which karyotype needs to be mentioned. It was done twice, and twice it was 46XX. So we can take it as a 46XS in this case. Coming to the examination part, general examination is normal, and her blood pressure is 116/80 in the left arm sitting posture. There is mild facial acne and fine hair is noted over her upper lips, and her height is 176 centimeters with an upper segment lower segment ratio of 0.87. Her BMI is around 21, and breast tanner staging, it is almost absent, and pubic hair P4 and axillary hair is present, which is indicating that pubarchy is present, and there is mild clitoromegaly noted. In fact, it was due to her clitoromegaly that this patient was referred to me, and there were 2 orifices seen on external genitalia examination, and it looks clearly like a female external genitalia with mild clitoromegaly, and there is a gap between the first and second toe, and there is crowding of fourth and fifth toe with a short fourth and fifth metatarsals.
Okay, Dr. Sekhar, we'll just stop for a moment because this is a very, very important slide, and this will actually give us very strong clues which is there. So yes, clearly, as you mentioned, this is a tall girl who has got no breast development, no pubic hair development, with significant pubic hair development, which basically means that there is a discrepancy between the estrogen and the progesterone effect. Yes. So the possibilities which we are looking at, what would you think clinically from that perspective here?
Clinically, we think that there will be some estrogen defect, sir, whether it may be deficiency or resistance.
Yeah.
And internal pubarchy has taken place as there is pubic hair.
Yeah.
And at the same time, there is hyperandrogenism as there is clitoromegaly.
Yeah, so these are very, very important pointers. So what things we can really exclude out of here is definitely this cannot be a multiple pituitary hormone deficiency because she's tall and she's having a normal pubic hair development that is absent. Of course, AIS and all those things are anyway out because there is no breast development and pubic hair is there. Aromatase deficiency, do you can rule out here?
Slightly less for now at this time point, we cannot rule out, sir. It is one of the possibilities.
So I think the key message here is that you've got good estrogen effect, lack of estrogen effect, while androgen effect is there, or it may be exaggerated. So if you ask clinically to me, I would say aromatase could be a good clinical possibility in this scenario. And the height, however, is pretty tall. So that, of course, so basically, if you talk clinically, I would say we can narrow down to either estrogen deficiency or resistance. And deficiency, most likely, we are not talking about some, of course, most XX gonadal will not have that level of height. So that makes it a bit unusual. So as we discussed, there are 4 major causes of tall stature along with the a primary amenorrhea. So AIS is out of that. Aromatase deficiency and estrogen receptor defect, yes, both of them are possible. And XY gonadal dysgenesis, do you think would be possible?
No, sir. XY gonadal dysgenesis less likely.
That is also very, and you have karyotype, which is XX. So by the time you have already narrowed it down to just 2 things, estrogen receptor problem or a aromatase deficiency. So I think that's the way that you took in such a wonderful history and examination. We can just reach to that narrowing of that. So carry forward from there. Yeah.
Yes. And this is my clinical impression after history and brief examination. We have poor estrogen effects as depicted by absent breast development and tall stature, suggestive of estrogen deficiency or resistance, and clitoromegaly depicts hyperandrogenism. And after this, I have forwarded to the hormonal workup. Her 8 AM cortisol was well within normal limits, and we can see elevated FSH 40.88, and LH is also elevated, and we can see elevated testosterone 99.12, and here we can see estradiol is updated, that is 58.8 picograms per ml, and AMH is well within normal limits as is 17 OHP, and we have an elevated androstenedione, and the ratio of 17 hydroxyprogesterone to 21 deoxycortisol to the cortisol ratio is 0.33. As there is loss of feedback mechanism, we have an elevated FSH. And the basic biochemistry.
If you can please go back to the previous slide again, very important messages as you were saying. We have this hyperandrogenism. Now, this hyperandrogenism, why do you think it's happening?
This hyperandrogenism is happening because we don't have any feedback mechanism, sir. Estrogen in the hypothalamo-pituitary gonadal axis. So LH is stimulating this.
Absolutely.
Cells.
Yeah. So this is a very interesting scenario that your LH is also high, and that is driving the ovarian androgen production. So you've got this mildish hyperandrogenism going on. And when we say estradiol of 58, what we need to understand that we have a girl who has stage 1 breast development. So usually around 40, we start thinking that periods can happen. So somebody with stage 1, this 58 is pretty high. So this is normally, if you talk about that way, it is not looking very high compared to a normal adult female. But for somebody who is B1, 58 is high, which means that there is estrogen resistance basically in that scenario. So I think this is a very, very important history examination which gives you the clue. Thank you. Carry forward, please.
After this, her basic biochemistry workup, including the fasting plasma glucose, postprandial lipid profile, and her calcium profile, and KFT and LFT were within normal limits. Then we move forward to look at the interesting part of her bone age. X-ray left hand wrist was done, and it clearly showed a delayed bone age, and her bone age is around 13 years, and her epiphysis was also not found to be fused. We know that we need estrogen action for the epiphysis to be fused, and ultrasound abdomen was done, which clearly showed very small size uterus, only with a thin rim of tissue visible, and importantly, both ovaries of normal size and echo texture, no ovarian cyst seen. And then MRI pelvis was carried out, which revealed bilateral ovaries of normal size and a hypoplastic uterus. And to see whether the estrogen effect is not there, we have also done DEXA scan, which revealed a Z score of -2.2 at spine and -1 at left femoral neck. we know that estrogen has action on the cancellous bone, and that is the reason why there is osteoporosis present at the spine. So coming to the key differentials in this case, we have impaired estrogen action or estrogen deficiency, as depicted by no breast and periods and tall stature and open epiphysis with delayed bone age and high FSH with hyperandrogenism, as reflected by clitoromegaly. So if we narrow down, we have a 46XX karyotype and presence of Mullerian structures, which suggests possibilities like aromatase deficiency, which is supported by clitoromegaly, elevated testosterone, and normal E2, low to normal E2, and estrogen receptor defect, which is substantiated by elevated LH and FSH, delayed bone age, osteoporosis, and normal to elevated estradiol levels. And very rarely, as we have distal abnormalities in this case, I had a DD of POR deficiency. And last probable differential diagnosis I thought was primary ovarian insufficiency.
Yes, I think these are very, very important differentials. And if you look at it now, if you go more in details, you have got the ultrasound which does not show an ovarian cyst. Generally speaking, POR deficiency and aromatase usually tend to have a large ovarian cyst. And for ovarian deficiency, I think the height is a big issue again. So 176 height, we have to think of either it's a XY-DSD, difficult to explain from that. But I think this is absolutely very nicely summarized to the real point in that regard. So carry forward, please.
Now, genetic testing has been planned. Initially, clinical exome sequencing was sought to cover the genes that cover all the differential diagnosis. But then whole exome sequencing was advised, as all the genes were not covered. And in this particular patient, aromatase gene sequencing also came negative. We had a defect of ESR1 defect. ESR1 is a gene which stands for estrogen receptor alpha, and they found to be a homozygous mutation located on exon 1, where cytosine has replaced adenine on the complementary DNA, leading to the shift of amino acids. So the final diagnosis in this case, comparing the history, examination, and biochemical workup along with genetic testing, would be estrogen resistance syndrome due to the defective estrogen receptor alpha. So after this, I have reviewed the literature. There have been only 7 cases published till now, and 5 are in females and 2 are in males. All these 7 are from 4 families. The first case has been described around 1993 in a male. After 19 years after that, the first female case has been described in 2013. Then we have 2 sisters from Jordanian family with 1 brother, all 3 from single family, that is published in 2016. Recently, in 2021, there has been another 2 sisters having similar presentation. So all the females described till date had elevated gonadotropins and estradiol and amenorrhea, and multicystic ovaries, hypoplastic uterus, and poor breast development and tall stature, with delayed bone age and open epiphysis with decreased bone density. But except 1 case among these 5 females have sibling, which is actually a sibling of a case which has been detected. In this case, the estrogen has been only moderately elevated, and there are no cysts in the ovary, which is similar to our case. So this different phenotypic variation can be due to compensatory pathways that are mediated by estrogen receptor beta or G protein coupled estrogen receptor 1, or it can be due to the rapid non-genomic actions, and it can also be due to the pathways that are still yet to be characterized.
And what were the usual elevations of estradiol in other cases? Till what level?
It is more than 1000, sir. In one case, it is around 3000, sir.
Okay. So yes, so I think it may also be related to the severity of resistance. So there are so many other factors, as you mentioned, which can explain that. Yeah,
Yes.
please carry forward. Yeah.
And the management is definitely challenging in this particular case. And in first case that has been detected, the patient was tried with conjugated estrogens and as well as with high dose estradiol. But both these treatment had no effect. And in the same patient, they have tried norethistone, which reduced the estradiol concentration. This norethistone, by decreasing the gonadotropin drive, it also decreased the ovarian cysts and size of the ovaries. This has been tried in the first case with only partial success, and in the second and third cases, they have been trying estrogen receptor alpha agonists like tamoxifen and raloxifen and clomiphene. They were tested to promote the transcriptional activity of the mutated estrogen receptor alpha, but unfortunately, no effect has been found. Now, the further studies are happening to act on the below pathways, that is below the receptor. They are trying to act on the co-activator pathways, like what's the therapy going on in the cancer. Still, we can try high dose of estradiol in some cases.
So I think that's a very, very interesting case that you mentioned. And probably because your estrogen levels are not very high, if we raise it to a higher level, maybe there is a response. And there was apparently bleeding also, which happened in this case. That means that there is some estrogen responsiveness which is there. So this might be a slightly different spectrum, but a very, very interesting case. And as you discussed, the distal part, basically, which will be there, which are going to be affected from that perspective, which is something which we can treat out in that regard. So I think this was a very, very interesting case which we had encountered. And thanks, Dr. Shekhar, for sharing this. And we'll now carry forward with the second case, which is about in the similar direction. So we have talked about estrogen resistance. We are now going to talk about another interesting scenario of when the estrogen is there, but it is not working. What could be the possible causes in that perspective? So for that, we have got a very interesting case again lined up, and I like to invite Dr. Dhwani, who is there, who will be presenting this case from our side. And this was an interesting case whom we encountered. Invite, just share the screen. So Dr. Dhwani, you can start from here about this girl. Please keep posting the questions. We'll keep it towards the end on that regard.
Good afternoon, everybody. So moving on to the next case, we had a girl with primary amenorrhea who had high androgen and low estrogen levels. So we had Miss N presenting to us at 13.5 years of age, who was born to a non-consanguineously married couple resident of Kolkata, who first presented to us in December 2016 with chief complaint of delayed puberty in form of no breast development and not attaining menarche, but having had a pubarche. A very important history that the mother shared was that at birth, the child was born with ambiguous genitalia in form of clitoromegaly with labioscrotal fusion and no palpable gonads. Thus, a diagnosis of XX-DSD was made and child was evaluated for the same. On evaluation, she was found to have a karyotype of 46XX. 17 OHP was 25 nanogram per ml, which is borderline elevated. However, her serum electrolyte and BP was recorded to be normal. Thus, a diagnosis of 21-hydroxylase deficiency CAH was made. The child was started on hydrocortisone, fludrocortisone, and underwent clitoroplasty and vaginal dilatation. However, on serial follow-up, it was noticed that the 17 OHP levels remained in the normal range. The child continued to have normal electrolytes and blood pressure recordings. So the practicing clinician tapered hydrocortisone level and advised a genetic workup, which was negative for CAH. This hydrocortisone was gradually tapered and stopped, and it was found that even after stopping hydrocortisone, 17 OHP levels remained within the normal range. Thus, this was definitely not CAH that we were dealing with. Subsequently, as the child grew up, she presented with delayed puberty. She was worked up and found to have very low estrogen levels, thus she was started on estrogen, following with some breast development was seen. Now, at this stage, she presented to us. So we had a girl with XX-DSD who was definitely not CAH and now presenting with a delayed puberty. So what were we dealing with?
So just let's go back to the initial history that's there. So you can continue. So we have a child who had atypical genitalia at birth and XX-DSD, and normally we say whenever XX-DSD is diagnosed, we say it is a 21-hydroxylase deficiency. Now, what will be a pointer that this is unlikely to be 21-hydroxylase deficiency? One, of course, if it's a salt wasting form, you will have salt wasting, but anything else postnatally which will tell you that this is not most likely CAH.
So again, what we need to look at is 70 OHP level of 25 is very less. 21 hydroxylase deficiency will usually have something more than 100 in that range.
The other important thing would be whether there is a postnatal worsening of the atypical genitalia, whether the clitoromegaly is increasing or it's regressing. So if you have a scenario which is increasing, means there is a postnatal androgen excess which is going on. But there could be other scenarios in which you only had during the antenatal period. And after birth, that scenario goes off. So suppose you have a girl who comes to you at 3 months of age, let's say, who was born with atypical genitalia, but the parents give you a clear-cut history that there is no increase in the phallic size since then. It's unlikely to be 21-hydroxylase. What are you looking at in that scenario? You're looking at a girl who had antenatal androgen excess, but postnatally there is no androgen excess. What do you think is happening?
So there was something that happening in the antenatal period where mother's hormones were basically converted to, like, were not getting adequately
converted. So one thing you are saying is that your mother's hormones were going inside the fetus and causing a problem. The other thing is that the fetus also produces certain compounds which are converted to a hormone. So fetus is a big producer of DHEAs. And this DHEA is converted via the placental aromatase into estrogen. So if you have aromatase deficiency, you will have a lot of production. But postnatally, everything comes down, so you don't have a worsening. So this would have been the other clue that postnatally there was no worsening in that regards. So now you can carry forward. You showed a scenario in which you had got androgen excess to begin with, and now you have got estrogen deficiency. So now I think, like Dr. Sekhar's case, it was very, very clear now what are you dealing with in this scenario.
Yes. So let me just finish off with the examination. Her weight, height, and BMI were essentially normal. Her SMR, her Tanner staging on estrogen supplement was a B3 with stage 4 pubic hair development. Bone age was significantly delayed at 10 years with chronological age of 13.5 years. On investigation, she had very high LH-FSH levels with undetectable estradiol level and very low AMH level, suggesting a primary ovarian insufficiency.
So how is it different from the previous case, if you go with this finding?
So estradiol is undetectable here. There we had high FSH and a high.
So that's what I'm saying, that if you have no breast development, and even if you have good estrogen, it means there is a resistance. You don't need it to be in a very 1000 ranges. But here clearly you have an undetectable estradiol. Why do you think AMH is there? What is the AMH marker of?
Ovarian function.
Ovarian function, largely the small or the mid oocyte function is determined via AMH. So do you think your diagnosis, whatever you are thinking of, affects the AMH level as well?
There is estrogen deficiency, so it will lead to, like, it will affect the ovarian reserve.
Yes. So what basically happens is that androgens are bad for the oocyte. They don't allow the oocytes to grow up well, and estrogen protects the oocyte. So if you have anybody who has got antenatal or a long-standing estrogen deficiency, you will also have a oocyte damage. So that's why your AMH is gone down in this scenario. So we'll discuss about that later on. You can carry forward.
So with all this information, where do we stand? So if you go by the algorithmic approach of excess DSD, that is the primary pathology the child had come with. So answering the question, the child had ambiguous genitalia, she had no palpable gonads, Mullerian structures were visualized, 17 OHP level, although slightly elevated in the first visit, remained low always. So 17 OHP was negative, and she had normal BP records always. So the next question that was missed out was history of maternal virilization. When she came to us and when we went back into the history, we found that the mother classically gave history of second trimester hirsutism and change in deepening of voice that had persisted since. So in our database, we have a child with XX-DSD who had history of maternal virilization, presenting to us with delayed puberty, poor breast development and absent menarche, but presence of pubic hair and a delayed bone age. On workup showing high FSH, LH levels and very low estrogen levels. So this gives us the diagnosis of aromatase deficiency with primary ovarian insufficiency, which was confirmed on genetic evaluation. Targeted gene sequencing revealed 2 novel heterozygous mutations, likely pathogenic variants in the aromatase gene. Thank you. So the take-home message here is, not every child with elevated 17 OHP level is CAH. An algorithmic approach to DSD prevents misdiagnosis. And in girls with aromatase deficiency, they usually present with atypical genitalia with history of maternal virilization. Pubertal development is often absent in such cases with delayed epiphyseal fusion, presence of ovarian cysts on ultrasound, and a continued growth into the second decade of life. Low estrogen and high androgen suggest this diagnosis, which is usually confirmed by genetic studies.
I think that's a very nicely presented by Dhwani, and it is very interesting scenario. So if you look at both the cases, these are rare scenarios. But if you carefully look at the history and examination, you will be able to make the diagnosis very clearly. So again, a girl with delayed puberty, she presented a bit early. The reason for that was that they were very concerned right from the birth. So if she had waited, it would have been more manifested features. But delayed bone age, around 3-4 years bone age delayed, despite having given estrogen. So she was given some estrogen for some time. Otherwise, it would have been even worse. With a history of hyperandrogenism at birth, along with estrogen deficiency later, clearly goes into your aromatase deficiency in that regards. She is now a young girl who is doing her graduation, in fact, completed her graduation, and on a reasonable pubertal induction, responded very well, and she is having normal periods, normal breast development. And because we have suppressed the entire axis, she is not having hyperandrogenism as well. Because if you don't suppress, whatever she will produce will again be androstenedione, and that will not be converted there. So again, a tall girl, normal pubic hair, no breast development, low estrogen, with a DSD, think of a aromatase defect. So aromatase defect is clearly the one which is involved in conversion of androgen to androstenedione to estradiol. To be more precise, the manifestations are mostly with maternal virilization, early onset and delayed puberty, and some milder forms may actually present with like a PCOS differential, but they will usually have a large ovarian cyst which are there in that perspective. So now we have discussed about 2 interesting cases, one in which estrogen was not being formed and the other estrogen was not working. Now we'll move forward to another 2 groups of 2 individuals who had tall stature with amenorrhea. And for this, I like to invite Dr. Guru Prasad. Dr. Guru Prasad, kindly share your slides. And this is again a very interesting case scenario. So Dr. Guru Prasad is an endocrinologist who is working at DiaLife Center in Bangalore, and he has been actively involved with regards to various aspects of our initiatives. And over to you, Dr. Guru Prasad, to kindly start with this interesting case.
So thank you for those kind introduction. Am I audible?
Yes, please go ahead. Yeah.
Good afternoon, everyone. This is the case of, again, a primary amenorrhea in a tall girl. And this case was, 28-year-old female who presented to us very recently with primary amenorrhea. And she was born out of non-consanguineous marriage, and she was 4th by birth order. And there is no family history or any history in her siblings of similar complaints or infertility. And she had a very significant past history. There's a history of surgery for bilateral inguinal hernia when she was 10 years old. And some specific questions were asked, and mainly there's no history of any virilization during puberty. And in fact, to see this case, in total, actually a diagnosis of Mayer-Rokitansky-Kuster-Hoster syndrome, that is Mullerian agenesis, was made all these years, because now she's 28 years and she had seen a lot of gynecologists because of primary amenorrhea. And every time she was, she was undergoing ultrasound scanning, and the ultrasound reports used to come as absent uterus and intact ovaries. So with just a structural, diagnosis, they used to call her as MRK syndrome. But the worst part is that she was also told recently that, she can opt for oocyte extraction and IVF surrogacy, because in MRK syndrome, you will have intact ovaries, and always this is an option. And so she got married recently, and she's in fact sexually active too. But now, post-marriage, she approached, because she remembered that the earlier gynecologist had told her that oocyte extraction is a possibility. So now she approached an infertility specialist for undergoing this procedure, and infertility specialist in turn referred her to us before planning for oocyte extraction. So on examination, all her vitals were normal. In particular, BP was normal, and again she was tall for her in her family, and she had crossed her parents' height. She was measuring about 170 centimeters and weight of 66 kgs. And in pubertal staging, she had stage 4 breast with absent pubic hair and absent axillary hair. And systemic examination was normal, but except for a bilateral inguinal scar. So the investigation wise,
Dr. Guru Prasad, if we stop here, you have got a girl. If you can go to that, back to the previous slide on examination. If we go back with our algorithm, you have a girl who has got stage 4 breast development and pubic hair, which is 1. So which means that the estrogen is there and working. So it cannot be estrogen receptor defect or aromatase deficiency, but the androgens are not working. So do you think it fits into with MRKH?
No, sir. In MRKH, you will have a normal, breasts as well as normal pubic hair. There won't be any ACTH or any other, problem.
So I think this is a very, very interesting fundamental thing on examination. Yeah. We had evaluated, if the people had treated earlier had evaluated carefully, as you did for the pubic hair, they could have immediately said, no, this does not look like MRKH. We have to think of something else. So as we discussed 4 causes of tall stature with primary amenorrhea, we already discussed 2 of them, aromatase deficiency, estrogen receptor defect. This again is interesting. Androgen insensitivity becomes an important cause of differential, and a tall girl also. That also is a big clue which is there. So it limits your differentials also. Please carry forward.
Yeah. So just by clinical examination wise, we are sure that we are not dealing with MRKH. So now let us see the investigations. The basic investigations again showed us the similar picture. Here again, we have an elevated LH level of 18.9, but FSH was normal. Then the TSH prolactin was normal. AMH was much elevated, more than 23, and both testosterone free and total were elevated with normal estrogen levels.
So why do you think, Dr. Guru Prasad, you have a discrepancy between LH and FSH?
Yeah, because LH, gonadotropes do have androgen receptors, and we know that LH is regulated by negative feedback inhibition from the androgens, and these receptors are not functioning, so the androgens are not suppressing the LH. Whereas FSH, the regulation is by the negative feedback inhibition from the inulin levels, which will be normally acting in these people. So unlike in gonadal dysgenesis, where both will be elevated, this is one condition where we have LH elevation, but not FSH.
I think that's a very, very nicely you have put this out. And this is again, a very interesting biochemical finding. Somebody who has got a high testo, definitely for a female, it is high, but for a male also, it's on the high end of normal. And your LH is also high. So testo should suppress LH. There's no confusion about that. If high testo, high LH, it is an androgen insensitivity. I think that's a clear-cut clue. And FSH is normal because of your inhibin suppression. So this feedback and all these concepts play an important role. If you remember Dr. Shekhar's case, we had got a high LH, and that was pushing the androstenedione, and that was causing all that DSD and some clitoromegaly which happened in that regard. So I think clinical and this thing, your diagnosis is pretty clear here on that. And estrogen levels are also on the higher side because your testo is slightly high and you are aromatizing them into estrogen. Please carry forward, Guru Prasad.
So the main investigation which we are waiting was a karyotype. And this makes the whole diagnosis very, very very specific that we are not again dealing with MRKH. That is, karyotype wise, we got 46XY. So we are dealing with 46XY DSD. So MRI scan, unlike all other previous ultrasound scans, again showed that the patient was having bilateral ovaries visualized. So I can put it in a thing that it is a ovaries what they have mentioned. We are not sure whether they are really ovaries because the karyotype we have got is 46XY. So radiological wise, the features were suggestive of MRKH.
So if you look at the AMH levels, if you look at the testosterone levels, this cannot be an ovary. This has to be a testis, a functional testis. That's why you have a male range AMH. You've got a male range testo. So this is clearly, I think that's because they have found some gonad. So it's an intra-abdominal testis. That's what we can, I think, conclude from there. Yeah, please carry forward. Yeah.
So again, because of that radiological thing, we were concerned whether it is CAS and versus MRKH, but it was very clear from the beginning, from clinical examination, that we are not dealing with the MRKH. So if you see MRKH and CAS, karyotype is the main thing which differentiate this. In MRKH, it is 46XX, whereas in CAS, it is 46XY. And again, the pubic and axillary hair will be normal in MRKH, but will be absent or sparse in CAS. Again, the testosterone and the AMH levels, which is elevated in our case, again rules out MRKH. So now we are left with the 46XY with a normal female external genotype. So now, should we stop at CIS or should we see for something else? So what could be the other differentials in case of 46XY with normal female external genitalia? So we have four main DDs. One is the CIS. Second is the complete gonadal dysgenesis in 46XY, that is Swyer syndrome. It could be the distal part of androgen biosynthetic defects, because in the past history we never had any history suggestive of any crisis. So we are dealing with something distal part of the androgen biosynthetic defects. So if we see these four features, four pathological entities, now let us come to the Swyer syndrome. Could it be a Swyer syndrome? So what happens in Swyer syndrome? We have complete gonadal dysgenesis. So the dysgenetic gonads will not produce any gonadal steroids, including the AMH. So here we see Mullerian structures to be intact. So this is not there in our case. Again, Swyer syndrome, we are able to rule out with just one feature. Apart from that, secondary sexual characteristics also will be absent. But in CAIS, again, we have normal AMH, in fact, elevated AMH, and we won't see any of these Mullerian structures in spite of a normal female external genitalia. So this holds good in our case. So if you see, the second main thing is the secondary sexual characteristics in which breast development will be normal in these people, but absent or sparse pubic hair. Again, this is holding good in our case. And if you see the other two, that is 17 alpha and 17 beta HSD D3 deficiency. So in 17 alpha, again, there won't be any Mullerian structures, there won't be any secondary sexual characteristics, but the important aspect in this, there will be elevated blood pressure. That is hypertension. Most of the times it will be seen, if not in all cases. So in 17 beta HSD D3 deficiency, again, there won't be any Mullerian structures and secondary sexual characteristics will be absent. Blood pressure will be normal. But one important clue, clinical clue, what we see in these patients, because our patient is already at 28 years, you could have seen this aspect, that is pubertal virilization. So what happens is that during puberty, these patients tend to have extraglandular conversion of androstenedione to the testosterone. So you could see this pubertal virilization, which was not there in our case. So now it's very clear, both biochemically, karyotype wise, and clinically, that we are dealing with complete androgen insensitivity syndrome. So if we look into this aspect, some few lines on this pathological entity, that is the CAIS. It is X-linked recessive disorder with mutations in the androgen receptor gene. The prevalence estimates is almost 1 in 20,000 to 1 in 90,000 genetic males. So the presentation is quite different. When we see an infant with the CAS, the main presentation is with bilateral inguinal or labial swellings. So it has been advised that any infant with bilateral inguinal or labial swelling, we are supposed to check their karyotyping. Karyotyping is very mandatory in these cases. So when these patients present in adolescence, usually the presentation is in the form of primary amenorrhea. So as we know this, that the karyotype will be 46XY with a normal female external genitalia. So again, as we already stated, the increased AMH, there won't be any Mullerian structures, but the normal breast development because of the aromatization of excessive androgens. Again, sparse pubic hair, elevated testosterone levels and estrogen levels. And again, as we already discussed, elevated LH levels, but normal FSH levels. So I did some simple literature search to know what is the commonest gonadal location in these CIS patients. Out of the 1 or 2 cases that has been identified in the literature, in one series, they have seen almost 52% of these cases, the gonads are in the abdominal location. See, in another series, they said that almost 86% the location of gonads were in abdominal. And it is also seen in these case series that patients with these abdominal testes had aberrant pelvic ligaments extending medially from the gonads. So now it makes us clear that whatever the MRI or the ultrasound features, if they said that could be a ovary or hydrosalpinx, which stated, could be, I think we are looking at abdominal testes with some medially extending pelvic ligaments. So now how to prove this? I think the main thing what we have to wait for genetic workup. That will tell us the clear cut. But still, again, we need not wait for this because we are 100% sure with the biochemical thing that we are dealing with androgen insensitivity syndrome. So what next for this patient? We are planning for an exploration and gonadectomy. And again, gonadectomy in these patients with CIS is quite controversial because the risk of germ cell tumors pre-pubertally is very, very mild. It's almost about 0.8 to 2%. So conventionally, it has been now seen that gonadectomy has to, we have to wait for gonadectomy till they cross the puberty because we need all these gonadal steroids for secondary sexual characteristics. So since our patient is at 28 and it's actually the high time that we have to plan for a gonadectomy in this patient. So post gonadectomy, we have to plan for a hormone replacement therapy. So the conventional hormone replacement therapy is with the estrogens, mainly to maintain the secondary sexual characteristics, bone and cardiovascular health, and also to promote general well-being and sexual function. And there is no role for progesterone because here we don't have any uterus here. So there is one more thinking that is coming up actually, whether these patients do better with androgen replacements. So there are few studies, mainly which I have quoted there. It's a very elegantly performed study, which showed that when we replace them with the androgens, the psychological well-being and sexual functioning is far better when you compare with the patient who are taking, who are being given estrogen replacements. However, presently the conventional treatment would be estrogen replacement.
And when we are talking about androgens, what doses did they use, Dr. Guru Prasad?
I think they had used very high doses actually. They had quoted somewhere between 300 to 900 milligrams almost once in 2 weeks.
Yes.
That was they had used it. Yeah, so they had seen a lot of adverse effects, in fact, in that group.
So I would be very cautious because even for partial AIS, we have to give very high doses. So this complete AIS will require huge amount of testosterone and that will have many other effects. So we know that there are other receptors or a non-receptor effect, some membrane receptor, and all those things can cause a confusion. So this was a very, very interesting case, Dr. Guru Prasad. Thanks for presenting. And this case really looked into a case which was actually diagnosed as MRKH and based upon the absent scenario, but then when examined was found to have no pubic hair development. And in fact, was being evaluated by the infertility specialist for possibility of ovum pickup and then use in the form of a surrogacy in that perspective. So again, gives a message that we need to have a careful clinical examination. Tall girl with primary amenorrhea, normal breast, no pubic hair development, think of a AIS as a possibility in that regards. So we'll now move forward to the last case, which is there, which Dr. Vibha will be talking about this very interesting case. So till now we've discussed about estrogen receptor defect, aromatase deficiency, and AIS. Now we are carrying forward with the theme of tall girl with primary amenorrhea. So Dr. Vibha, you can continue from here.
Thank you, sir. Good afternoon, everyone. So we have another case with a tall girl. She presented to us with at a 7-year-old, and she was born of non-consensuous marriage. And she came with the complaints of no breast development and no menstrual bleeding. And there was no history of any delayed menarche in mother and delayed shaving in father. No history of any chronic illness or poor appetite. And there was no history of any vomiting, headache, or delayed difficulty in visions, no anosmia, and no history of any vitiligo and alopecia. And there was no history of any recurrent hospital admission and recurrent illness. And there was no history of any recurrent weight gain or constipation. And when we asked further, she gave that she has a surgery for abdominal mass. When she contacted her doctor, she told us that mass was probably the germinoma. So it's not moving forward.
This girl was presented basically with the delayed puberty and apparently an abdominal surgery. So this.
On examination, her vitals were completely stable. BP, she was normotensive, no blood pressure was not high. And on anthropometry, we found that her height was more, that was 164 centimeter, which was more for the girls. And on the general examination, there was no any significant examination we found. We found the breast stage was 1 and there was no pubic hair. So the tennis stage was 1 at the 17 year of age. On the systemic examination was completely normal.
We stop at that
Yeah.
one. So you now have a girl who had presented to us with tall stature, with primary amenorrhea, and who has got a breast which is no breast development and no pubic hair development, which is there. What do you think you're looking at? What do you think is a problem here?
So if we look only the breast development and no pubic hair, then our DD will be like chronic illness of MPHD, but there is no history of any.
No, so you have now seen there is no breast
Tall
development
now
and
coming
no
to
pubic
the
hair with
No.
tall stature.
now coming to the tall stature and no pubic hair or no breast development. So we should be thinking of any this steroidogenic defect like 17 beta HSD could be the cause.
So we talked about the tall stature basically is associated with 4 things with primary amenorrhea. What are the 4 things?
So one is this AIS, one is XY gonadal dysgenesis, one is aromatase deficiency, one is estrogen receptor resistance.
Okay, so let's go one by one. Can it be AIS?
No, so because
Because
the
there
breast
is no breast development. So AIS is out. Can it be a estrogen receptor defect?
No, sir.
Why?
So because there is no pubarchy.
No pubarchy. Aromatase again, no pubarchy.
No
So those
pubarchy.
3 are out. So the only differential which is there to
X-gonadal.
us is the XX DSD which is there. So that XX DSD could be a gonadal dysgenesis or it could be a steroidogenic defect. Both of them can cause this scenario. So again, as we talked about all the 4 cases, tall stature gives you a big thing. And the other cases, the 3 cases did not have a breast development.
Yes, sir.
The AIS one had a breast development. So again, if you look at breast and pubic hair and height, you will get the diagnosis.
Providing pubic hair like
Because of the delayed bone age.
So X gonad, we're talking about XY gonadal. So in which completely gonad is gone and everything is delayed, and that's why the adenarche is also not pushed into the picture from there.
Looking into the investigations,
On a combined adrenotesticular
Testicular.
biosynthetic
NRP5A1.
that's an
NRP5. The USD shows the uterus was present and it showed the right ovary and the left was not visualized. In the biochemical investigations, the LH and FSH both were high and the estrogen and testosterone both were very low.
So what does it mean?
So the gonadotropin levels are high and this whether it is a testis or ovary, both it is not
So we
working.
have got 3 cases. The first case was there in which you had got a high LH and FSH and estradiol levels were 50 or 60 and testo was also high. That turned out to be a estrogen receptor problem. Then we had the second case in which estrogen was 0
and
but testo was high, which means it was more like a aromatase
deficiency.
Then we have got this third case in which you have got 0 testo, 0 estrogen. What does it mean?
So there is a gonadal failure.
So completely the gonad is not working at all. And probably this gonad is not an ovary. Because this can only happen that you're not having any androgen production. Because otherwise, if the ovary is producing something, then androstenedione will come up, some production will be there. So probably this is a testis which is completely non-functional, not producing testosterone. Of course, then estrogen is not being produced and not producing AMH, which is causing the uterine development, which is there. So normal uterus is there. So this is the way to look. So if you look at the LH, E2 and testo of all four cases, you can easily understand. But CAIS, what was the scenario?
In CAS, the this AMH was high. That is
AMH was very
high. Testo was high.
Testo was high. Estrogen was
high.
So in that case of AIS, you had got a high LH. You had got a normal FSH and you got a high testo, high AMH along with that, those scenario and estrogen. So that was a different scenario in which the gonads are not there in that perspective. Here, what you are seeing is that you don't have any production of test. So basically, the gonad is not working at all. And FSH is also very high. What does it mean when you say FSH is high?
Means the inhibin is not being pumped.
Yes. So inhibin is also not working. So if you contrast this to the AIS, their LH was around 20. It was not very high. And FSH was around 2. So FSH was normal. So this means that there is no inhibin also. So there is a bicellular testicular failure. This is what you can say from this report. So if you talk about a biosynthetic defect, now can a biosynthetic defect present like this?
So in a biosynthetic defect, there will be some adrenal problem. There will be electrolyte difference also.
FSH, high FSH.
FSH high, no, there will be LH.
Inhibin will be produced in that scenario. So biosynthetic defects also become unlikely. So this becomes like a classically a gonadal degeneration in that scenario.
Somewhere like a POR and that kind of deficiency.
POR and also inhibin B, if it is being produced, it will suppress FSH. So in
plus they will have some androgenic features.
Some features. So this is like zero estrogen. So she is a tall girl, so estrogen is not working on the bone. There is no breast.
That's
no
why.
Working.
That's why no pubic hair,
No
delayed bone age.
But why is the adrenals not producing? Is the question which we have to probably address later on as well.
So we have a girl with no secondary sexual characters. No primary amenorrhea and the high FSH and low estrogen. So what could be the differentials now? It could be Turner, no, because the height is more. In Turner's, we got short stature. Steroidogenic defect, star SSC, we got salt wasting, 17 hydroxylase, we have hypertension. And aromatase, we have generally high androgen, as in this case, we have low testosterone. 17 beta HSD, there is no this puberty virilization as discussed earlier. Autoimmune, there is no history of any chronic, there is no history of any vitiligo alopecia. So it is less likely.
Very early.
Very early.
So that means the ovary were damaged too early.
Too early.
Unlikely.
Gonadal dysgenesis, yes, as sir has discussed. It could be the possibility. So we have, then we ordered karyotype, and when it came out, it was 46XY. So,
and now that history became important. So we got the history of it having germinoma later.
Yes.
They said there was some abdominal surgery which was done.
Yes, sir.
So that history now becomes very significant.
So we have a girl with 46XY karyotype with uterus, with non-palpable gonads and with the female external genitalia. So on combining these, what could be our next differentials? It could be, if we combine 46XY and uterus, the possibility could be AMS deficiency and resistance. And if we combine 46XY and female external genitalia, it could be AIS. But if we combine all these three, The possibility is 46XY with gonadal dysgenesis.
So basically, the whole gonad is not working. It's not producing AMH, it's not producing estrogen, it's not producing
Testosterone. Then we sent the genetic testing, and when it came out, it showed that the patient has a mutation in NUP 107 gene, and it does ovarian dysgenesis, and it shows the likely pathogenesis in this case.
Ovarian?
Yes, sir. Yes, this is a
I've seen this patient.
yeah. This is the similar patient. There is a this. So what is this NUP? This is yes, ma'am. So what this?
Who brought up MRPH along?
Yeah, ma'am. Similar patient with that. So this NUP 107 is basically a nucleopore complex gene. It interacts with the tissue specific factors, and it is required for the development and maintenance of the gonads. And during the meiosis 1, in response to the DNA damage, it binds with APAF1 and mediates cell cycle arrest. So when there is a mutation in NUP 107, the meiosis DNA damage response decreases and it leads to the oocyte death. This is the basic physiology that the NUP07 does. So, but in our case, this.
So I think this is a big dilemma.
Yes,
so we
sir.
have an XY individual, and we have got a gene which is affecting the oocyte. So whether there is a double hit model, something else caused this to develop, like a female ovaries developed, and then those ovaries were damaged. We are not very sure about that. Can you think of anything?
The similar, it might act at the level of germ cells. So it probably is at a very so because they have done, this might be a new kind of a diagnosis. So they have only found it in people who were.
So we have to see whether it also has a testicular. So we should report this because it's a very interesting. So this is
the action if it is acting on the germ cells.
And we have
not only oocyte death, it can cause germ cell death in the testes also.
Not only germ cell, we are talking about death of the Leydig cell and the Sertoli cell also. So this is a bit different.
Germs are not there, which cause
they can survive.
Impure
in testes they can work that. So even if you have got zero sperms, you can have Leydig cells which are functioning. So it's a bit different.
That's a thing, zero sperm. So right from the time of differentiation of the
germ cells.
So when the germ cells in embryogenic period are traveling to the area, this, because of the Y chromosomes, they stimulate the development of the Leydig cells and the Sertoli cells. So I'm not saying acquired kind of a defect where the Leydig cells are protected. Here, because it's an interactive. So at the level of maybe something new.
So we have to definitely inquire into that, because the thing we were thinking of, it's mainly affecting meiosis. So if it affects meiosis,
it will affect the germ cell.
In females, but in males, the meiosis happens at a very late stage. In oocyte, the meiosis happens at an early stage. Testicular sperm meiosis happens only in puberty. So it is not fitting it, but definitely it has to be something which is some mechanism it is working separately.
So not
also.
This mechanism.
So not this mechanism, but this is a very, very interesting scenario, and that's why we brought up, because this is an individual who is tall, who has got no breast development, no pubic hair development, who has developed a germinoma. So there is a gonadal dysgenesis.
Not
this one. And she had already developed a germinoma. So there is a gonadal dysgenesis which is there definitely. So we have to remove the gonads, and all those things are there. The second gonad also has to be removed. But we have not reached the root cause of the testicular. So whether how this can explain is a question. You can just explain a few of the studies.
Did you take picture of that patient? This patient?
She'll come and I'll take the picture. Okay. There are some cases.
She had a little bit. She's the same Muslim patient.
Ma'am, she's the one. I'll bring it. Yes, ma'am. She's broad. She has broad shoulders.
Her muscular. So that's why we did the testing. She had a little bit of clitoromegaly also. So maybe this happened somewhere in the middle of, say from the 7th week onwards, when the testicles have been differentiated, and then the hit happened.
And the other thing which we cannot explain is that why is there no pubarchy? Because adrenals are there. So whether the gene is also having some androgen production is also being disrupted somehow.
Somewhere.
So this needs to be looked into. You showed what the research
was. There were this study was done, and they studied two daughters in the same family, and they have reported this NUP 107 in these two sisters. And they have studied the same variant in the mice, and what they have seen that there was a subfertility in the female mice, but the this male mice was normal. The testis of male mice was normal, and
So only with NUP.
107. And the similar study was done in the Drosophila also, which also showed this. The eggs of the Drosophila females were affected, but the testis of the male Drosophila was normal. This was shown in this. So this is the
Effects at a later stage.
Yeah.
So
That is, but whether there are some other effects or there are some other gene which has been missed out. So everybody, every human will have 20 to 30 genes which will cause a disease in somebody else, and they may not cause. Suppose there is a male. If the male has got this gene defect, he doesn't have any effect on him. But there may be some other genes which we may not have picked up because we are doing a clinical exome sequencing, not the whole exome sequencing. So that will be the way forward to go for the whole exome. But this is a very, very interesting scenario which you have mentioned in that regard. Yeah. Yeah.
It would have caused any problem. But she has something else which we haven't found out.
Yeah.
So maybe two things are leading to this problem.
So anyhow, this was a very, very interesting case. So we have had 4 cases which we discussed today. All 4 were tall. And along with tall stature, they had got issues in terms of primary amenorrhea. The first case basically had an issue in terms of tall stature, along with there were problems of estrogen which was detectable. There was normal pubic hair development. So estrogen was around 50. So you had high estrogen, and along with that you had primary amenorrhea, turned out to be a estrogen sensing receptor defect. The second case was a girl who was born with atypical genitalia, then from there moved forward towards primary amenorrhea. So androgen excess to estrogen deficiency turned out to be aromatase deficiency. The third case, labeled quote unquote as MRKH, actually presented with tall stature with normal breast development and sparse pubic hair, and then was found to have a AIS. And if you look at those pathophysiological picture of a slightly high LH, normal FSH, high testo, high estrogen, that is a typical biochemical picture of AIS. And finally, this case, a tall girl, again, no breast, no pubic hair, and masculine habitus, also was suggested a XY, history of germinoma, and clearly you had got no AMH, you had got no estrogen, you had got no testosterone, and you have a strange gene defect which is causing, which cannot really explain. So this is something which is very interesting. So we show that if you have a tall girl with amenorrhea, there are only 4 things which you should widely consider: estrogen receptor problem, aromatase deficiency, XY-DSD, which includes AIS and all those phenomena, and the gonadogenesis, which is there from that perspective. So just to summarize, this is a typical case of a primary amenorrhea: good breast development, good pubic hair development, reasonable height, everything is normal. So we are basically dealing here more with a structural defect. So we have developed a part of our pathway which helps you reach the diagnosis based upon the algorithm. So this is most likely a developmental defect from that. So at the end, we like to thank all of you for joining. You can go and have a look at our website, which gives you a lot of information about these aspects. We'll address the questions as well. And you can also have a look at our programs, which we do on a monthly basis, our publications, as well as the mobile application. So before we close, we will address a few questions which are there. The first question is from Dr. Shruti: how to differentiate FSH receptor resistance from hypergonadotropic hypogonadism? So this is an interesting scenario. So if you look at the way the ovaries are developed, if you have a FSH receptor resistance problem, you will have ovarian cysts. Multiple ovarian cysts will be there, which are there because ovaries will develop till that phase, and then the problem happens. So you will have multiple cystic appearance which will be there, and you will have isolated FSH elevation. So that will be different from the primary gonadal failure. And this problem will happen right from birth. So there will be no breast development at all. FSH is mandatory for pubertal development in girls. LH is mandatory for pubertal development in boys. If you have a FSH problem in boys or a LH problem in girls, you will have puberty, but it will not be sustained. So if you have a FSH receptor problem, you will have complete lack of pubertal development. You won't really get confused with the typical picture of POI. Any differential resistance to estrogen with normal breast development and hypoplastic uterus. So what it means is that we know that there are different areas, the co-activators and the co-repressors who work differently in different regions. So there may be variations, there may be different sensitivities, but if the receptor is defective, you will have the same effect.
More likely as an ultrasound report being reported as hypoglycemia. Very common that when you see a patient of primary amenorrhea, routinely the ultrasound report, more dedicated radiologists who would basically use, so they are not exactly a hypoplastic.
Yeah. So next question again by Dr. Shruti is, how do we explain endometrial thickness in the second case with untreatable estrogen? So I think Dhwani had mentioned that she had already received some estrogen from outside. By the time she came to us, she had been given some estrogen. And despite that, the bone age was 10 years. Despite getting estrogen, the bone age was 10 years. And there was, of course, some growth happening in that. Dr. Supreet is asking about the mid-parental height. So everybody was tall for the family. It was very, very clear. So they were pretty tall from the family. The second girl was not tall, but she had a delayed bone age. So that was the aromatase presenting at an early age. But all the other three cases were tall for the family. It was very clearly from that perspective. And they were all in the male range, so to speak, in that perspective. So at this point of time, we like to thank Dr. Sekhar and Dr. Guru Prasad. It was a wonderful interaction, very, very interesting cases. And we like to have closing remarks from Dr. Sekhar first.
Yes, sir. Thank you. And one thing I found from all these cases is we need to have a suspicion. We need to do a better review of literature. And in my case, what I found is I was always biased towards multicystic ovaries, which was found in the previous cases of aromatase deficiency. And I was biased towards aromatase deficiency. And after discussion with you, then we had a target panel gene. Then I arrived at a diagnosis. So we need to be broad.
I think that's a very, very important message to look at the whole picture. And often the diagnosis is there. All these four cases, even though we are talking about rare cases, some basic phenomena will give you the diagnosis. Dr. Guru Prasad, your message.
Yeah. So thank you very much, because you were supported from the day one, and even in this case. And in this case, it really, helped us. The main take-home message is, don't just go to the radiologist and ask for the diagnosis. In endocrinology, I think we need to have both clinical as well as biochemical and genetic-wise diagnosis, not just a structural diagnosis.
I think that's very important message, because if somebody is saying that ovaries are there and you get confused, there is an abdominal gonad. That will be a more specific mention in that regard. Then you said 52% of CAIS will have abdominal gonads. So they will be labeled as testes. If you have a high AMH, you've got high testosterone. This is clearly in that perspective. So this is, I think, a very, very interesting discussion we had. So this key message which we have is that if you have a girl with primary amenorrhea, you expect them to be short. That is Turner syndrome, that is MPHD or whatever, or celiac disease. If you have a tall girl with primary amenorrhea, you have to start thinking, okay, there is something unusual. Like we say that if you have non-ketotic hypoglycemia, you start thinking of hyperinsulinism. Tall girl with primary amenorrhea, only 4 differentials, maybe more, but these are the 4 which we had thought. One is a estrogen receptor problem. Your estrogen will be detectable in that scenario. Aromatase deficiency, you will have hyperandrogenism and your estrogen will be 0 in that scenario. AIS, you will have no pubic hair development and you will have a high testosterone, high AMH, high LH, normal FSH. And finally, gonadalogenesis, you've got no AMH, you've got no testosterone, you've got no estrogen, and you will make a diagnosis. So XY, DSD, XY gonadalogenesis, estrogen receptor defect, aromatase defect, as well as a complete AIS. These 4, all the 4 cases we discussed were tall. So again, clinical clues are the crux. And if you look at the height, the breast, the pubic hair, you will get the diagnosis in amenorrhea. I'll thank all of you. We'll be uploading these presentations on our channel and the YouTube channel as well. So thanks everybody to join. Thanks once again, Dr. Sekhar and Dr. Guru Prasad, for taking valuable time from their practice off for this presentation. Thank you.
Thank you.